Hello, Amy, this is Sarah. Can you hear me? Okay. If you can hear me, I cannot hear you yet, so.
Good afternoon, everyone. This is Trish Vandersee with the North Carolina Healthcare Association. Thank you for joining us today for our webinar, Aspire to Knock Out Pneumonia Readmissions Webinar Series number 5, Deliver Effective Post-Discharge Transitional Care. Deliver Effective Post-Discharge Transitional Care. We would like these webinars to be very interactive, so we're anticipating that you will be highly engaged in today's session. We encourage you to ask questions and share information throughout the webinar today, utilizing the question and chat panel. We will keep all lines muted to cut down on feedback, distractions, and echoing. Before we get started, I'd like to go over a few logistics for today's webinar. All lines are currently muted and in listen-only mode. Please chat with your colleagues, hosts, and panelists throughout the webinar today utilizing the chat panel. You can find it by clicking on the chat bubble at the bottom center left of your control panel. Please make sure your to setting is set to all panelists and attendees. This session is being recorded and will be made available on NCHA's website and through email notification shortly after the conclusion of this session. Presenting today is Dr. Amy Boutwell, founder of Collaborative Healthcare Strategies, and at this time I'm going to go ahead and turn it over to Dr. Boutwell.
Okay, great. Thank you, Trish. And oh, I'm hearing an echo. Okay, great. Thank you, Trish, and welcome everybody. It's great to be with you on a hot August afternoon. So thanks for taking the time. I hope you're all somewhere cool. I just want to make sure that you, while you're on the webinar, that you have figured out where to find the chat panel. And so if you go to the options here on the Zoom platform, if you don't see chat, click on more. It's more and it's a dot, 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 at least on my screen, and click on more, and that's where you'll see chat listed. And so I just want to make sure that that you do have the chat open. Thank you, Tracy. Thank you, Anna, to make sure that you have found where that is and that you're able to participate in the discussion during our webinar today. So thank you so much to those of you who have figured that out. All right. Well, just as a reminder, it's been a while since we were together. We took July off, and so I hope you're having a great summer. The purpose of our Knockout Pneumonia Readmission series, I hope you know, is to share best practices in reducing readmissions overall, adapting those best practices to our specific target population here in the collaborative, which is pneumonia patients, and really connecting the concepts and the best practices to action that you're taking with your teams and your patients day to day to reduce pneumonia readmissions at your hospital. We'll focus on high leverage strategies, and really today represents the end of the curriculum for content, and we will start to move into implementation coaching. So we've been so thrilled with the enrollment and participation on these webinars over the past several months, and we've covered a lot of material to be sure. And so again, we're so appreciative of you participating and attending these webinars, and we really want to set the vision for our next several months, which will recognize that we're coming to an end of sharing a lot of the content, which hopefully you find helpful, and we really want to start to talk to you, hear from you, and interact as a shared learning environment to really accelerate your action and your success on reducing pneumonia readmissions. So as with always, we hope you're coming today with questions, your day-to-day challenges, any examples, data, and your own ideas for improvement, especially with regard to today's topic of delivering enhanced transitional care services. So you'll all be familiar, hopefully now, with the ASPIRE Guide, and the ASPIRE Guide is the Agency for Healthcare Research and Quality's guide, fully titled Designing and Delivering Whole Person Transitional Care. And so as we've learned through the webinar series so far, one thing that distinguishes, if you will, my experience and my approach to reducing readmissions is that while there are some really important root causes that we absolutely need to understand about disease-specific readmissions, and there's also disease-specific target populations who need and warrant our attention, just like pneumonia. There's a lot about the root causes of readmissions and the changes we can make that start to become non-disease specific, even when we're trying to serve and improve care for a disease-specific target population. So these are the two messages that we've been sharing with you through this webinar series, which is pneumonia readmission rates, we all know, high in North Carolina. They're tough everywhere, really, but that's what brings us together is our pneumonia patients have really high readmission rates. We're all committed to getting those down, and we really want to understand the root causes of pneumonia readmissions. Some of them are very specific to the experience of having just been hospitalized for pneumonia. We've talked about some of those in prior months in terms of, well, maybe they were septic and they were pumped full of fluid, and now they're, we can expect that their heart failure or their diabetes is going to need active close titration and management in the post-hospital period, or we've just put them on broad spectrum antibiotics, and we can expect and anticipate we need to monitor people for the development of either antibiotic-associated diarrhea or C. diff. So there are, and there are other examples, and I encourage you to type those in. What have you learned about the pneumonia-specific root causes of readmissions? And then there are general causes of readmissions that occur for heart failure patients and COPD and pneumonia and cellulitis and alcohol use disorder and everything in between. And those are things that I hear a lot from you about appointments and self-management skills and affordability of medications. And those by no means are specific to the experience of having just had pneumonia. They are much more general to what causes any hospitalized patient to be at high risk of returning to the hospital. So this has been the curriculum that we're covering, and today I'll remind you, as I said, we're coming to the last major topic in the driver diagram of the ASPIRE guide. So the ASPIRE guide, you'll remember, is called Design and Deliver Whole Person Transitional Care, and you'll see here on the driver diagram that we have learned that successful efforts to reduce readmissions at the population level, meaning the pneumonia population level or the total hospitalized population level, are characterized by work organized in these two buckets of data-informed strategic design of your readmission efforts and excellent high reliability delivering of the services that meet the root causes of readmissions for your population. So you can see down here, we are at the E part of ASPIRE, and today we'll be talking about delivering enhanced services for high-risk patients. This just kind of situates you where, while we're coming, as I said, to one of the major milestones in the collaborative of covering the ASPIRE content according to that driver diagram, we're still only halfway through, which is great news. And as we come to the end of very heavy didactic series of webinars, we'll want to spend the rest of our time together in webinars and office hours and shared learning environments to really talk about your work to reduce pneumonia readmissions. And you'll see here there's a little bit of an updated schedule from when last we met in July. We are now planning our fall in-person meeting to be on November 2nd. So you might have heard about this, but I just want to make sure that you are up to date. We're looking at November 2nd to get together in person. Consider it an in-person workshop. It will be a working meeting, highly interactive, and I might even surprise you and have no PowerPoint slides. Okay, so it's time to roll up our sleeves and really talk about your work, your action plans, and problem solve together. So that's what you can get out of coming November 2nd. And September and the following webinars in November and December will be what I like to call coaching calls and open office hours, where we'll talk about the implementation of action plans and specific actions, because we know that you're very busy at work, and we want to make sure that we're applying what we're teaching you in the content to your day-to-day transitional care efforts to get results, because that's really what brings us together. So the objectives for today's topic, we are going to talk about the importance of designing post-discharge services and supports that address the root causes of your pneumonia patients' readmissions. So I want you to really come with me now and think about your pneumonia patients and the pneumonia patients who have been recently readmitted to your hospital, and think about not whether or not they had a post-discharge appointment, or not whether or not they had good med rec done, but think about those people and why did those people come back to the hospital? Did they come back to the hospital? Did their home health nurse send them back to the hospital? Did their PCP refer them back to the hospital? Did the skilled nursing facility transfer them back to the emergency room? Who are these people, and what are the circumstances under which they ended up returning to the hospital within 30 days? We want to laser focus in on the factors that cause your pneumonia patients to be readmitted. And then we want to deliver post-discharge transitional care services and supports that address and mitigate those root causes. So the key here is, the key for this topic in delivering effective transitional care, as we're going to discuss in detail the rest of this hour, is different from what I'm just going to go back to in the driver diagram. It's different than what we covered in a prior webinar, implement whole person transitional care for all. This is the step where we do good med rec, good teach back, maybe make post-discharge follow-up phone calls, and ensure that people have post-discharge appointments in place, and maybe even the transportation means to get there. That goes in this bucket. When we get all the way down here, it's like a funnel. Now we're talking about actual service delivery in the post-hospital time period that we're going to invest in for the purposes of helping a group of patients successfully recover and recuperate during the 30 days post-hospitalization so that they don't have to come back in. And so the key to doing that well is to connect the dots between the root causes of readmissions in that target population and the services we deliver, not making them generic, but making them very specific. So think for yourself for a moment. For which patients do you deliver pneumonia-specific transitional care? So pneumonia-specific transitional care, maybe that's pulmonary rehab, or maybe that's ID follow-up, or maybe that's a post-sepsis clinic, or a post-discharge clinic for pneumonia patients. And so think to yourself, what about enhanced services is specific to the condition of pneumonia? And what about post-discharge services is general to addressing whole person transitional care? So again, that balance that we're striking here in our Knockout Pneumonia series that says pneumonia is really important. Our patients have a very high readmission rate. There are some services that are going to need to be pneumonia specific, and there are some services that are going to be whole person in nature, not specifically designed to address the condition of pneumonia. So think about that as we go through. So you'll remember that I've shared this slide with you before. The premise of success in the ASPIRE guide is to take a data-informed approach to designing your readmission reduction efforts. So we always start with what is our aim, and in the Knockout Pneumonia series, our aim is to reduce pneumonia readmissions by 20%. What does our data and root cause analysis show? And we've gone through that in the first couple webinars of this series. So you know that your pneumonia patients who are discharged into skilled nursing facility care or even home with home health care paradoxically have a higher readmission rate than you might have thought. You might also have learned from our all payer analysis from the NCHA that younger adults have pneumonia readmissions as well as the older adults. And so we've also learned that Medicaid adults have pneumonia readmissions just like Medicare adults do. So this is where we look to you to use your data, and hopefully you've identified whether or not you're focused on all pneumonia readmissions or all pneumonia patients, or if your data and root cause analysis suggests that you're best off focusing on a subgroup of your pneumonia patients, again, because that's what your data shows. So I would invite you, if any of you are on the chat, if you could just share with us what is your pneumonia target population. That would be incredibly interesting for us right now. So once we identify that we're targeting either all pneumonia patients or a certain group of pneumonia patients, then the question is, what should we do to achieve our aim? So that's what services should we deliver to reduce pneumonia readmissions. And what I want you to think right now is, think to yourself, and please, please chat in if you have some ideas. What would it take, if you will? Let's take a step back from the busy hospital floor, take a step back from how difficult it is to do warm handoffs, take a step back from how hard it might be to get PCP follow-up appointments in a timely manner, and just think to yourself, now that you know your pneumonia patients and you know why, you're getting to know why they get readmitted, answer the big picture question. What do you think it would take in order to drive down pneumonia readmissions? And I'd love to just pause here and wait for 5 brave people to offer any sort of ideas. So what would it take? Would it take fixing the transportation system in rural North Carolina? Would it take free medications for everybody? What would it take? What do you think? What would it take to drive down pneumonia readmissions? Not what are you limited by in today's imperfect system, but if you were to say, I now know how to reduce pneumonia readmissions, whether or not you can make that happen is a different question. So does anyone want to be brave enough? Say, what would it take to help these pneumonia patients not come back? I'll bet some of you know. No one's going to be brave enough. Okay, well, I encourage you to every so often come to your readmission meeting and ask each other this question. Often in hospital care and hospital-based quality improvement, or even cross-continuum quality improvement, you know, we're limited by what we perceive is possible. That's availability bias, right? If we've never seen it done before, we assume it can't be done. That's called availability bias. And what we as quality improvers and as clinicians and quality people and administrators and leaders, what we need to ask ourselves is what is the solution? Not being limited within our box, but saying, what do these pneumonia patients need? So Janelle was kind enough to say interoperability. So it's a beautifully succinct term there, and it sounds like Janelle might be thinking it would be really helpful if we could see each other's records, I'm assuming. And that if we could see each other's records, we could know when was the last, what meds was the patient on, when was their last appointment, what was the plan of care, so that different providers and clinicians across the continuum can be literally on the same page. So that's a great example of, thank you so much. It take to reduce pneumonia, readmissions for pneumonia. We covered this last time, which is the driver diagram. Hopefully, and by the time we get to our November working session, you're all going to have a driver diagram for your pneumonia readmissions. So This is just an example, but it happens to be an example from a real-world successful program of the work that gets done in the different domains of time and setting for pneumonia patients. And so I just gave you this most simple of examples, which is, what do we do for pneumonia patients? We refer all of our pneumonia patients to the Transitional Care Service team. And we know that that's possible because we've quantified it to say that we only have 2 pneumonia discharges per day, and we've all decided that that is feasible for our pneumonia transitional care team to handle 2 discharges per day. In the spirit of cross-continuum collaboration, we know that not all of those 2 discharges a day go home, and many go, or some fraction of them go to skilled nursing facilities. So we know that those people are at very high risk of readmission, and so we execute a warm handoff with a circle back phone call for all of our pneumonia patients who go to a SNF, and that's about 2 discharges per day as well. And finally, we deliver enhanced services because this team said, just like Cynthia is saying in the chat, thank you, Cynthia, this team said, well, if we wanted to help keep people from coming back to the hospital, we've got to monitor them, right? They were sick, they had pneumonia. We put them on broad spectrum antibiotics, we pumped them full of fluids, we held their antihypertensives, and then we restarted them and we switched them from IV to PO antibiotics the day of discharge, and no wonder these people come back, right? And so what this team said is, just like what Cynthia said, is, you know what, people really need to be seen. We need to lay eyes on our patients frequently, especially within those first couple days and week of discharge. So I love what you said, Cynthia, and that's what we have here on the driver diagram as well. It turns out that this team, as you'll hear in further examples, decided, well, do we really need a clinician, a doctor or a nurse or a pharmacist? And it turns out that in this particular example, this was a rural community hospital, small-sized community hospital in a relatively rural part of Massachusetts. So I'm correcting myself because I remember we're here in North Carolina today. And so rural Massachusetts is not the same as rural North Carolina. So it's a small community, relatively rural area of western central Massachusetts. And what they really decided was they needed someone who knew the community resources. And so they could afford and they could deploy a small transitional care team comprised of 1 social worker and 1 community health worker to follow these pneumonia patients who are discharged for 30 days. And what the social worker and community health worker did was that sometimes they worked together and sometimes they worked in parallel, but they really focused on making sure that people had access to food and transportation, and were connected to services and benefits and faith-based organizations and volunteer organizations and other services in the community that would address their whole person needs, not just the pneumonia recovery clinical element of their journey. So this is what this I would propose to you, and I do share with you that for this small hospital, they reduced it happened to be heart failure and pneumonia and COPD readmissions using this exact model. They reduced their readmissions by 30% over 2 years with exactly this model, right? So when I say what would it take, it really kind of takes what Cynthia said, and agreeing with Janelle's comments as well. It takes follow-up. It takes following along with people. It takes helping them once they leave the hospital. And that's the answer to what would it take. And just because some people need help once they leave the hospital doesn't necessarily mean that it is unaffordable for our healthcare system. So this hospital that you see here represented on the slide, this hospital was getting absolutely crushed by Medicare readmission penalties. And so in the long run, having success on COPD, pneumonia, and heart failure readmissions through this essentially two-person team is going to pay off dividends as soon as they climb their way out of the penalty zone, isn't it? So you can see it's a relatively small, concrete, but small investment in staff resources in order to actually get very impressive results. So let's talk specifics. Delivering transitional care to high-risk patients. What do I mean by support and service over 30 days? So one of the most profound lessons I learned early in my research and field work on reducing readmissions came from a social worker in North Philadelphia. And I was studying models of transitional care, meaning, you'll all know the Coleman and the Naylor model, et cetera. And, what was good for patients? What was working out there in the real world? And this transitional care clinician, who happened to be a social worker, she just had absolute clarity of vision. When I was asking her questions about what types of services and supports and follow-up and appointments and phone calls and how often do you call people, and I was asking all sorts of detailed questions, and she just kind of sat back and looked at me and she said, I just think there's always going to be a group of folks that's going to need someone to help them, and that's never going to change. Think about that. That is the voice of experience right there. I agree with her. When she said it that simple, and when she said it that clearly, and when she said it with 32 years of social work in North Philly behind her, you just say, yes, that makes a lot of sense. Some people just need help. And it's not necessarily about coaching, and it's not necessarily about making sure their med list is right or their appointments are made, because that won't be enough. And that's what this transitional care social worker taught me. And I would encourage you to bring this quote back to your teams and discuss it. So when we talk about enhanced transitional care services, I put that term, the adjective enhanced, up there to specifically remind us we are talking about all of the things that we would do extra for patients that are not part of standard care. So standard care these days would be to use teachback. I mean, would any of us on the phone say it's acceptable to not involve patients and their family or their care partners in developing a discharge plan? No. In fact, in most states, it's law. Would any of us say that it would ever be appropriate to not use appropriate health literacy terminology and teachback techniques to engage with in teaching at the point of discharge? No. Would anyone say it's appropriate to not do a good, accurate medication reconciliation? No. And increasingly, we're all coming around to saying, making appointments is becoming standard of care, and making post-discharge follow-up phone calls is also becoming standard of care. So what I want us to do in this webinar is put those steps and process improvements, put those in the webinar that was called Improve Standard Care for All. And today we're talking about enhanced transitional care services. And these are additional services and supports in the time period following the hospitalization, after the hospitalization, not during, after the hospitalization. These are services that are not provided to all patients as part of routine care. These are services, by definition, are offered to subgroups that we have identified as high risk of readmission. Usually, transitional care services are delivered immediately prior to, and after discharge, often extending for 30 days. And often, these services are delivered by hospital staff or contracted partners from other entities. But the hospital or the ACO or the bundle or the whoever is accountable for achieving results called reduced readmissions is the one that's paying for transitional care services in order to get the outcomes we desire. So that's a lot, and I welcome any questions. But this is what defines a success when we talk about transitional care. It's not the normal stuff we should do in the hospital. It's the extra stuff we do once the patient leaves. Now, at this point, people often jump to say, well, what do you recommend, Dr. Boutwell? Is it Coleman? Is it Naylor? Is it Bridge? Is it, is it enhanced care? Is it guided care? What model do you recommend? And that's not, we're not ready for that question yet. The model has to be matched. Being the model, meaning the services we deliver and the way we deliver those services needs to be matched to the target population. So there may be several target populations at high risk of readmission that you've identified in your own pneumonia data analysis. So even if we just focus on pneumonia patients, you have clearly identified that you have some segmenting of your pneumonia patients by risk of readmission. So you've got pneumonia patients who are discharged to home with home care. You have pneumonia patients discharged to residential or group home settings. You've got pneumonia patients discharged to skilled nursing facilities. You've got pneumonia patients with comorbid chronic illnesses like heart failure, COPD, AFib, stroke, aspiration. You've got pneumonia patients with behavioral health comorbidities. They are very high risk of readmission. We've got pneumonia patients who can't afford medications, who don't have insurance or can't afford the expensive antibiotics that we're prescribing for them, or others. And so, so I hope you see that before we can say what services should we deliver to our high-risk pneumonia patients, the first thing is to have clarity on which subset of patients, subset or subsets of pneumonia patients are we talking about. Because the services we deliver for people in these various subgroups, some of them will be universal, but some of them will be distinct, like pneumonia patients who can't afford medications, or pneumonia patients with behavioral health comorbidities. So it all depends is the answer, and that is not a non-specific answer. It's actually quite specific. It's me saying, I cannot tell you which services to deliver until you tell me which target population we're talking about. Again, I'm emphasizing this because this is one of the more common areas of pivot or redirection that I find myself sharing with teams when I'm working with them to get success. So when we think about delivering enhanced services to any high-risk population, it's important to recognize that one standard transitional care model will not likely meet the needs and address the root causes of readmissions for all of your high-risk populations. So it's not a question of, again, I'm using shorthand, Naylor or Coleman or Bridge or guided care or something else, right? It's a question of matching the service to the needs of the discrete target population. So let's talk about some of these models that I find particularly helpful. So in the general category of what defines effective post-hospital transitional care, I commend to you this quote from the director of case management in an inner city Baltimore hospital, who I think said it all in this one phrase. She said, "Our navigators are flexible, proactive, and persistent. They address all needs. Each of them has incredible interpersonal skills." So let's just take a moment and dwell on each and every one of those attributes. And each and every one of those attributes are in fact defining success factors for any transitional care program. Whether it's a transitional care program delivered by community health workers, advanced practice nurses, behavioral health specialists, peer recovery coaches, who am I missing? Social workers, whomever. And that's why I even took out the role type, right, in parentheses there. It doesn't matter what the role type was. What matters is what these navigators do. They are flexible. they're proactive, meaning they seek out their patients. They follow up proactively. They're persistent. When somebody says, no, I'm okay, I don't really need you to call me, or no, I'm okay, I don't really need you to come by, they say, yeah, I'm going to come by. It's my job. I got to check on you, Bob. You know, Bob, I've got to do it. My manager expects it of me, you know, and being persistent and proactive is actually a success factor. It is a programmatic attribute that I want you to look for and think about. Then moving on to, they address all needs. This is not just about doing an in-home med rec. This is not just about ensuring transportation or appointments. They're talking about what is it going to take to keep you stable, safe, and sorted out, really, for the 30-day time period. And usually, when we address those needs, whole person needs over 30 days, the patient and, you know what, the family unit is usually a whole lot better off in the long run. And then finally, each of them has incredible interpersonal skills. And this is also essential, because just like I said with this transitional care navigator talking to Bob, right? We need to be friendly, but a little bit, you know, proactive, as they said. We need to say, yeah, Bob, you know, I'm going to come and it's going to be okay. I'm just going to check on you. I'm not going to bother you for very long. And we need to have engagement skills. We need to be friendly, but we need to also convey that we've got a job to do and that we have some level of, you know, authority to do so, and that we are going to be helpful and we're going to listen to you, Bob. And so all of these things are wrapped up in having incredible interpersonal skills. And as I've worked with so many teams across the country, I have come in to teams that said, you know what, we really thought we needed a nurse practitioner. I'm just giving an example. We really thought we needed someone of a type on our team. And we hired a really amazingly high qualified nurse practitioner. But you know what? She didn't work out because she didn't want to do home visits, or she didn't work out because she just wanted to stay in the office and not engage in case conferencing or community building or whatever the case may be. And so not everyone, I think it stands to reason, not everyone would be a great fit. This is outreach. This is very interpersonal. This is very grassroots oriented. And for some people, they absolutely flourish in these jobs. And when we can find people who flourish in this type of a role, then they are our secret sauce. And that's what I really want you to focus on when you think about if we're going to have a small transitional care team, who should we hire? Hire for these attributes first. And then you can ask yourself, do we have a balanced portfolio of nurses, social workers, community health workers, pharmacists, or whomever else you want by licensure or role type? But really come back to this slide and remember how important hiring for aptitude for the job is. So as I've done work, again, with so many teams across the country on what is the best type of transitional care, I've basically moved away from named models of, this many visits and that type of service, et cetera. And I've moved into what we described in the Aspire guide as whole person transitional care. And so you can see the bullets here, the attributes and the verbs and the action words of what whole person transitional care looks like. And, I think that many of you who've shared over the months how challenging, how resource constrained your communities are, how impoverished your patients are, how limited they are in some, insurance coverage or in their benefits, or in their family support systems, or in their transportation infrastructure, etc. I think I invite you to look at this list and say, yes, this is what it would take to help patients in our pneumonia patients in our community do better and not have to come back so very often. So navigating, hand-holding, arranging for, providing with, taking a harm reduction approach, meaning not everyone, unfortunately, we're not going to get every pre-contemplative smoker all the way through, to successful abstinence when in the 30 days following, in the 30 days following a pneumonia or COPD discharge. And so we need to have the skills of helping people smoke less, smoke when they don't have their oxygen on, identify behaviors and triggers so that they're not smoking inside, they only smoke outside. And these are the harm reduction skills that, whether it's smoking or drinking or other problem substance use or other problem behaviors, we need to be empowered and skilled in harm reduction techniques so that we can meet people where they are, deal with their realities and their priorities, and move a realistic plan forward, not just a plan that you and me from nursing and medical school would have wanted to see on paper for them. A really important element of this work is work that we learn from obviously great nurses and the social work profession and the community health worker profession, which is that if we want to help people, we need to identify what their priorities are and place their priorities first, and our kind of medicalized priorities second. And so through establishing what we call a helpful, trusting relationship of service and engagement, if the priority is to get home from the hospital to take care of one's cats, right? You've all heard this one before, right? I don't want to go to sniff because I got to get home and I got to take care of my cats. There's no one to take care of my cats. Well, then guess what? Part of our plan is going to figure out, do we find someone to take care of the patient's cat so that she will be reassured and go to rehab, which is what we think is the best plan? Or do we mobilize services, supports, timely follow-up, and in-home services to get the patient home so she can be with her cats, and yet we don't lose her and we continue to intensify support for that patient because we knew we wanted her to go to rehab, but her priority was getting home to the cats, right? This is a classic example that happens everywhere. So these are the adaptations that I find, whatever the type of service is, think about these verbs and these attributes in terms of the success factors that I see out there. Now, I would be remiss if I didn't bring your attention to one specific evidence-based studied model of transitional care that I'll bet you haven't heard of. And it's the bridge model of transitional care. And quite simply, it's absolutely straightforward. The bridge model of transitional care is just a social worker is the transitional care staff person. And so a social worker is the one who meets with the patient briefly before discharge, follows up with them immediately after discharge, and then periodically as needed for 30 days following discharge. A couple of the key breakthroughs that I think using a social worker in his or her full capacity as a social worker is what you see here on the slide. And these are some very valuable lessons that I've learned from the bridge model as I studied it from these social workers doing this work. So obviously social workers look at the whole person, right? And so they look at the medical issues, they look at the behaviors, they look at the social needs, they look at the income, they look at where you get your emotional support from, they look at where you live, they look at how happy you are or how distressed you are. I mean, they look at the entire big picture. It's a very applicable lens when we're talking about a patient who's just left the hospital and looking at, looking at the person in context. They then they assess and they anticipate what types of needs is this person going to have once they leave. And so again, that's more anticipatory. Who are you and what type of needs can I expect you're going to have once you leave? I love this one. The social workers all tell me, well, of course those needs are going to change over time. I'm just going to say that again. They all say, of course the needs are going to change over time. That is so profoundly different from what we as doctors, nurses, and case managers kind of do on the floors of the hospital, where we think we assess needs and we make plans, and we expect those plans are somewhat static, right? We get, and I'm speaking in generality a little bit, but we get frustrated when those plans are not executed upon. And what I've learned from my community-based social work colleagues is that's not even the expectation of social workers, because they understand that every plan is applicable only when it's in a context. And when the patient is in a bed, in the sick role, wanting to leave the hospital, there's one plan that might be agreeable. But when they get home into the pressing, chaotic realities or other challenges of their day-to-day life, well, there's going to need to be a different plan and a retuning and an update of that plan. And so again, I think that skill is something we can all embrace, but I think it's a profoundly helpful way to think about transitional care, because we're literally making plans and following people as time passes and as they pass from one setting to another. So I won't walk through all of the bullet points on this slide, but what I really, just a couple other elements of the model would be, many people say, well, you can't provide social work support for forever. And one thing that's really great about this whole paradigm of transitional care, whether it's Coleman or Naylor or Bridge or whatever else, is the entire purpose of calling it transitional care, whatever the it is. The entire purpose of labeling a new set of services as, quote, transitional, is because the purpose is to intensify support in those days and weeks following hospitalization when we know people are high risk of readmission, sort out needs as those needs change over time, and then, as you can see here at the bottom of the screen, link people, mobilize benefits, link people to services, and establish the connection to the existing clinical, behavioral, and social services that exist in that patient's network, so that you can successfully disengage and move on to someone else after 30 days. So that's why transitional care is a helpful label. It reminds us that the purpose of this is to, assess and link and ultimately sign off. Okay, a couple examples. So these whenever you see these yellow examples, and again, I'm not going to read them all to you because I'm highlighting them to you for your reference as you go back to your teams and talk about this and follow up. But these are all from the ASPIRE guide. And so these are vignettes from the ASPIRE guide. We are talking about chapter 6 of the ASPIRE guide today. And so they're all referenced and discussed in fuller detail if you want to go to chapter 6. So this is the social work model of transitional care, the bridge model I was just talking about. And I wanted to highlight that I was fortunate to lead the national evaluation study of the bridge rollout site. And when we did a very rigorous Medicare claims-based analysis on the primary site that was implementing and developed Bridge, it's an inner city Chicago hospital and Bridge was deployed to any and all Medicare high-risk patients. It included the full swath of high risk. It was high utilizer, COPD, heart failure, pneumonia, poor social support, polypharmacy, and needing palliative care. It was the full definition of high-risk Medicare beneficiaries were referred to social work transitional care. And when we looked at not just the patients who got social work transitional care, but when we looked at the total population, it reduced readmissions by 20%. This is an incredibly strong result. And it really, would stand up to everything you've told us about the challenges of your pneumonia patients or your Medicare patients in North Carolina in general. And so that's why I'm spending so much time on this and on the concept of the whole person or the role of social work in helping to provide transitional care. Another example comes out of Philadelphia. I mean, there's so many examples, and I know you're all using community health workers as well, and that Community Care in North Carolina uses community health workers. And so I'd be remiss if I just focused on social workers. By no means. Community health workers play a very helpful role in providing that timely, day-to-day, frequent contact, emotional, kind of psychotherapeutic, social support, and logistical support. People need to know that they've got someone on their team, they've got someone, you know, of their community or from their community or nearby to them, kind of geographically, who understands them, who knows where we're all from, and who can be that friendly, helpful support person. And so I have seen a lot of success with community health workers on these teams. Now, I've described the two role types that I'm assuming you're not as frequently thinking about, community health workers and social workers for your transitional care team. Of course, you're thinking about pharmacists and nurses and advanced practice nurses, etc. And so I want to bring that together with one of the very best teams I've ever met out of Oakland, California. And, you know, of course, this is the beauty of the interdisciplinary transitional care team. So this is inner city Oakland, California. They're focusing, you know, on patients who are in the hospital with COPD, CHF, and HIV. And you can see here on the slide that their interdisciplinary transitional care team has a pharmacist, a COPD nurse, a heart failure nurse, a social worker, 2 community health outreach workers, and importantly, and not to be glossed over, a program manager and a data analyst. And this is how we know how successful this program is, because they put effort into managing, tracking, trending, analyzing their target population and their outcomes. And the important thing about, a couple important things about this interdisciplinary transitional care team is that everyone on the team is hired for the willingness to do in-home or community visits. And by community visits, I mean on a bench in a park at a Dunkin' Donuts or whatever they've got out there in Oakland. And they all have to be willing to do community outreach. Not even have to be willing, they all are expected to do community and home-based care. And that's pretty different from, you know, a hospital-based transitional care team who might be accustomed to doing phone-based work or office-based follow-up. So again, an interdisciplinary transitional care team really leveraging the skilled nursing, education, and disease-specific management elements. A pharmacist has been invaluable for them, and the social worker and community health outreach workers to really form those frequent helpful relationships and to provide frequent contact and to go find people when they start to fall out of care. So when we look at successful readmission reduction teams, and all of these teams I'm talking about are focused on not only pneumonia patients, but pneumonia, heart failure, COPD, high utilizers, patients with behavioral health needs. You know, this is the population that I know you're thinking, what in the heck can we do for these people? What in the world? We're trying, quote, everything. And when we really move into whole person care, it works. And so this is what none of these teams, it's really interesting to me, none of these teams know each other. They've never met each other. They've never even been in the same collaborative like we are here in Knockout Pneumonia. They're all from all over the country from different programs. And when I ask these different teams, tell me, what do you think is the secret of success? If you were going to tell some other team somewhere else, the most important thing that has gotten you the results that you have achieved, this is what they all say. It's amazing convergence of expertise and experience. They say, we look at the whole person, the big picture. We always address goals, patient goals, and ask, what does the patient want? We meet the patient where they are. First and foremost, it's about establishing a trusting relationship. You can't talk to someone about their medications if there's no food in the fridge. I've read the next one to you about our navigators are flexible, proactive, and persistent, and we do whatever it takes. And this is what I would say to you if you are delivering enhanced transitional care services. Come back to these quotes and come back to this experience of success and ask yourself, how close are we to this type of a model, to these types of services? So in the last few minutes, and we will get to this more in our in-person meeting as we go into action planning. But in our last few minutes, the story is not yet told on transitional care for 30 days unless we add one more element to the picture, which is we're going to discharge folks and connect them to transitional care services, and those transitional care teams, whomever they are going to be getting in touch with people and connecting with them and assessing and planning and linking them to services. But you know what? A whole bunch of them are going to come back to the emergency room anyway. And so what do we do when they come back to the emergency room? Here's just a few words to kind of get you thinking about this last part of the care process. So in Massachusetts and Virginia, where I happen to have done the analyses, I'm sure it's the same in North Carolina, of the patients that we discharge from the hospital, from the inpatient setting, about 25% of them come back to the emergency room within 30 days, right? So that's inpatient discharge coming back to the emergency room. It's not our readmission rate, it's the ED revisit rate. Discharge from the hospital, come back to the emergency room. 25%, 1 out of every 4, right? Your pneumonia readmission rate is like 18%. And so we know a whole bunch of people, 1 out of every 4 of our general discharges are coming back within 30 days to the emergency room. Here's the current state. This is from Massachusetts data. About 50% of those patients are readmitted, and about 50% of those are discharged. And so what that tells me, what that can tell you, and what I know, being a practicing doctor in the hospital, is that the native state is when they come back to the hospital, some of them go upstairs and some of them go home, right? We have an opportunity, if our patients are connected, especially to enhanced post-discharge services, we have an opportunity to tip the scales, if you will, on what you see in the right-hand side. We can readmit fewer and safely and appropriately discharge more. And maybe we don't even stop people from coming back to the emergency room, which of course would be desirable. But once they hit the emergency room, how can you know that that patient, A, was just discharged, and B, is in an enhanced transitional care program? And if you know that information, how can you push it to the ED provider to help her in her decision-making process to decide, Mr. Smith, sick or not sick, in or out? And so that's a rich, rich opportunity. And we're doing we've been doing statewide sprints on this in Virginia and Maryland and New York and Massachusetts. So I wanted to be sure to bring it to you, my friends, in North Carolina as well. So this is just Medicare data. It happens to be from Virginia. And so I emphasize it's Medicare data. And it's the ED revisit rate, right? I told you it's 26% in Virginia. And let us not be ageist. Look at our Medicare patients under age 65, so those are the dual eligibles. Look at those revisit rates within 30 days, sky high for the youngest adults, right? These are people, of course, with various disabilities, and that's what makes them a dual eligible patient. And so clinically, this makes a whole lot of sense. They're Medicare and Medicaid, so they also have poverty issues. They've got, all sorts of challenges. But this is just a reminder that when we think about people that we need to serve, even if we're limiting our view to Medicare, we can't forget the younger Medicare population because they are especially returning to the emergency room with very, very high frequency. So we're going to cover this in the next webinar. This is just a preview to get you thinking, what do you have in your emergency room? Can you identify that patient when they're coming back within 30 days? Many of us have flags now. Do you have a flag? Can we, if the patient is in a special service, can we notify that service? Can we get that service to respond to our patient in the emergency room or otherwise huddle and collaborate on safely and appropriately discharging them if discharge is the best option for that patient? So again, this is a vignette that I'll probably come back to when we talk about strategies to reduce readmissions in the emergency room. I'm just putting this on your radar screen because I would really like to ask you to come back in September, having asked the question, what are we doing in our emergency room to respond and try to reduce readmissions whenever appropriate. And you can read, I encourage you to read the vignette here. And what I'll tell you about the importance of this vignette is it comes from the program that led to the Pioneer ACO program in the United States of America. So this was the pilot, this was the success that led to the creation of the ACO program. So, and guess what? Their work was based in the emergency room. Identifying those high-risk patients who always and frequently come into the emergency room and wrapping our arms around them in that location and safely discharging them back into the intensive care teams in primary care and in the community who already know them. It is a beautiful model. It is obviously highly effective, and it is what is leading us through this phase of accountable care now in the United States. So as we break today, I'd like to commend to you the following recommendations between now and the time we get together in September. Do you know how many pneumonia discharges you have? Do you understand the root causes of your pneumonia readmissions? Have you asked yourself, what would it take to address the root causes of pneumonia readmissions for your patients in your community? Have you designed post-hospital supports and services that really address the root causes and needs of your pneumonia patients? Are you delivering whole person transitional care that's flexible and proactive? And finally, are you ready to spring into action when that patient returns to your emergency room within 30 days? And do you have processes in place to identify them and reconnect them to the services and supports you've already worked so hard to mobilize for them? So thank you so much for being with us today. Look forward to being back in touch in September when we will do some planning for our in-person workshop later in the fall. So Trish, I'll turn it back over to you.
Great, thanks Dr. Boutwell. What an awesome presentation today. I hope everyone was able to learn something from Dr. Boutwell today and is using the tools that she mentioned in there, as well as that we have been providing on our website. Our next webinar is September the 6th at 2 p.m. and we'll be sending out some information related to registering for that. And for those of you that are interested in today's recording, Sarah will be sending that out sometime tomorrow. That will go out through our listserv, and then all of these resources and prior webinars are available on our NCHA Pneumonia Knockout website. Again, thank you for joining us today, and that concludes today's session.